This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our Neurology podcast collection. Whether you are new to neurology and training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi there, it's Jeff Ratliff, Deputy Editor of the podcast, to introduce you to the final Neurology Recall episode for 2023. For this December episode, we have compiled a group of great interviews on topics in neurocritical care. Off the bat, you'll hear Derek Stitt interview Karin Diserens from the June 12, 2023 episode of the podcast. Derek and Karin discuss subtle clinical signs that may provide information about awareness in patients who are in an otherwise unresponsive neurological state. In the second interview, which comes from the November 6, 2023 episode, Hallie Alexander spoke with David Greer about updates to the guidelines surrounding brain death determination criteria. In the final two segments of this recall episode, we feature two interviews that discuss the communication that occurs in taking care of patients with neurocritical illness. In the third interview of this recall episode, you'll hear an interview that Maisha Robinson had with Monica Lemmon that aired on February 20th, 2023. In that interview, we learned about a new framework that can help guide communication of neurologic injury prognosis to infants in the ICU. We followed up this conversation with our last interview that aired on September 25th, 2023. In that podcast episode, Neha Dengayach spoke with Susanne Muehlschlegel and Adeline Goss about a study they conducted analyzing the conversations that neurologists have in family meetings for patients requiring neurocritical care. We hope these interviews will help you both engage in better clinical care for your critically neurologically injured patients, as well as inform the vital discussions that are had with families and loved ones during these times. We hope you all have a wonderful holiday season, and we'll see you in the new year.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Derek Stitt, neurologist at Mayo Clinic. This podcast episode is one you're going to keep in your podcast Rolodex, especially for those who do any critical care or acute inpatient neurology. But even if not, then still stay tuned because we touch on some points that are important and potentially eye-opening when it comes to how we think and talk about consciousness and responsiveness in those with significant brain injury. I am delighted to be joined by Karin Diserens, neurologist and acute neurorehab specialist at the Lausanne University Hospital, aka the CHUV, in Switzerland. One of Karin's areas of focus is consciousness assessment in those with critical brain injury, and she's here to talk about what I think is a very enlightening and motivating paper published in the Green Journal. It's in the Contemporary Issues section, came out in late February, titled A Focus on Subtle Signs and Motor Behavior to Unveil Awareness in Unresponsive Brain-Injured Patients, The Importance of Being Clinical. I thought this was a really well-designed article, and you start out the article with some helpful introduction and background on the landscape of consciousness assessment in those with severe brain injury and how difficult it can be. And I'm going to quote a line from your intro that I thought was really nicely distilled. It said that proving that an unresponsive patient is aware is hard, but proving that the patient is lacking awareness is harder, if not impossible. And so I was hoping you could start us off by giving us some background on the status quo of consciousness assessment. We can talk about where things were before you've proposed these new tools and this new flow sheet, and then we can get into what your group is advocating for.
One of the main problems is that the definitions of types of disorders of consciousness is not the same in every country. The Glasgow scale we're using each day, and indeed it's really quantifying only motor and verbal responses. However, some brain injury patients show a lack of command following using conventional neurobehavioral examination tools, but have a high level of awareness and capacity of language processing. Nevertheless, because of their behavioral unresponsiveness, cognitive motor dissociation patients appear clinical indistinguishable from those with a true disorders of consciousness and are therefore misdiagnosed. Why do you need these clinical evaluation? Why it's so important? And in this respect, diagnosis should not be limited to these standard clinical scores that we realized. And that was our motivation. Our observations were that assessing patients using the standard clinical scales, as I said before, only quantifying motricity and verbal command response, patients formed one group. Yes, we applied these scores, and we had one group with the same scores based on the Glasgow 4 and clinical scales. However, during the first evaluation in the intensive care, we differentiated two different types of motor behavior. One set of patients had akinetic motor behavior, and the other set had reflex movements and decortication and decerebration motor pattern. Akinetic motor behavior patients showed subtle little signs of consciousness perception, meaning signs of interaction by intentional movements. The other set of patients essentially had reflex reactions. The focus of our research, therefore, aims to expand the range of motor testing across limb, facial, and ocular motricity, allowing detection of subtle, purposeful movements. Even in the subset of patients classified as vegetative, we developed a new clinical tool for this that we call the motor behavior tool. Our observation was the subtle signs of conscious perceptions were in most cases associated with the characteristic of akinetic motor behavior as opposed to a pyramidal motor system behavior. We proposed the term of clinical cognitive motor dissociation in order to describe patients showing slight but determined motor responses. So we elaborated a flowchart, and the diagnostic flowchart compares the clinical examination with the results of structural imaging and neurophysiological examinations in order to search for neurological deficit intrinsically to the brain injury process and interfering with the production of appropriate behavior motor responses. It means we looked to have lesions in the strategic localization of brain responsible for motor planning or peripheral lesions responsible for motor responses. So strengthening the clinical evaluation by observing the motor behavior complemented by assessment consisting of an MRI independent of task-related and command-following activity and task-independent potential recorded by EEG. That is a new approach for these patients.
I applaud you and your group for your work on developing these processes, which are quite detailed, but they provide great guidance for those out there assessing an unresponsive patient. But I was hoping you could tell us more about some of the bedside assessment tools that you mentioned in this paper, specifically the Motor Behavior Tool Revised, or the MBTR, because that's a big part of the flow sheet. And so I was hoping you could talk about this tool more specifically. And I should mention that this tool is meant to be an adjunct to the coma recovery scale as a complementary tool.
What we do, we observe the motor behavior meticulously, looking at the negative signs. It means an array of reflexive behaviors and positive signs, which are subtle intentional movements. Sometimes you turn just around and the nurse say, hey, you see, he moved. And that is important to give the time to observe. The coma recovery scale says we have to be there 1 minute at least, and it's right. So this clinical neurobehavioral evaluation also integrates detecting pitfalls, and that's important to think to these pitfalls in beginning of your examination. When we make the flowchart, it was difficult when we think about our pitfalls. So it's good when you're examining the patients, you think where could be pitfalls of the motor afferents. Using a flowchart, incorporating a search strategy for potential concomitant pitfalls are gaps, compromising the production of a motor response that would hinder the correct diagnosis. That can be central or peripheral. We do our activity as an interdisciplinary transversal team, evaluating the patient's minimum 24 hours after withdrawal of sedation and repeated 3 or 4 times a week to ascertain the clinical diagnosis. So that's a complement to the standard scales used in every hospital.
Thank you so much for that background and that explanation. And as you say, it really seems like it's all about being meticulous, and it is going to take time. and time at the bedside and repeat visits, repeat assessments, but you can glean so much from doing that. It's certainly clear. That's a very helpful illustration. Now, it's not just this tool that you created, but you also outlined a very detailed flow sheet for assessing awareness. But first, I was hoping you could remind us about why it's important for us to assess for cognitive motor dissociation and what implications it seems to have regarding prognosis.
They are already in the acute phase a very big importance. Firstly, we should avoid considering an unresponsive patient as a someone unaware with hidden cognitive capacities, which induces important suffering for the patient, the family, and the caregivers, and compromising an adequate treatment approach. The caregivers and the families are just more motivating the patients often to interact, and when we come by and they don't know us, they don't interact with us. Therefore, we have to believe them. And secondly, a detailed clinical assessment using the MBD tool combined with a systematic search for confounding factors makes it possible to determine an appropriate clinical diagnosis of the patient's level of consciousness and to prognose cognitive sequelae on the basis of the impairment revealed by the paraclinic examination. This is important when the families want to know what we can wait for his deficits, how he will be in his dependence, that it's independent from consciousness. We have to know, we can anticipate with the local focal lesions what the patients could have of sure and less sure of deficits. And our recent publication of May 23 this year of the evaluation of the outcome of the patient after 1 year, confirming that is a significant difference in improved outcome, a better motor output, and a considerable cognitive capacity was seen for patients compared to true disorders of consciousness. Nevertheless, it's only one of the arguments of the patient's life decision. That's important. We really have to take account from the individual goals, what the patients would like, what the culture of the family, and this is only one part to decide where we are going with the patient.
Our listeners, to really get the most out of this content, would be certainly best served by going in and checking out the article and looking at those figures firsthand, because they are detailed. But I think it would be helpful and illustrative if maybe you could give us a scenario, whether it be hypothetical or an actual case, where you employed this model and how it turned out. And then if you can, maybe talk about still some of the limitations that still exist with this enhanced bedside approach, because a lot of our listeners may really have limited access to resources, might just have standard MRI, EEG, and then the bedside exam. So if you could maybe give us a little bit of an example of real-world application, I think that would be helpful.
I will report one of the first cases we published also in 2015. And this was a 50-year-old woman in good health who presented headache and vomiting for a few days, was found unconscious by her husband during the night. The patient was intubated and transported by ambulance to the emergency room. Glasgow score was 4. She was immediately operated for an oligoandroglioma. We observed in intensive care an extubated akinetic patient with bilateral ptosis, with no intentional movement except for a slight non-reflexive movement of a finger, but no intentional opening of her eyes. In passive eye opening, there were no resistance, no oculomotricity, and no fixation. She was classified coma by both scales, Glasgow and Coma Recovery Scale. Based on her akinetic motor behavior and the slight intentional movement, which could translate a preserved cognition, we searched for pitfalls as to why the patient could not interact. On the MRI, we found the explanation of the dissociation between motor interaction and slight signs of conscious perception. Multiple ischemic lesions, principally mesencephalic ischemic lesions, one important lesion in the midbrain caudal region corresponding to the localization of the central caudal nucleus of the oculomotor nerve. Our patient first opened her eyelids after 3 months, when her akinetic mutism had improved and when she was walking and talking again, confirming that her unresponsiveness was due to blocked motor output rather than unconsciousness. And no disorders of consciousness patient would walk after 3 months independently. That was for us a very important experience, that once we have to look for the deficits, we have to look for the pitfalls, and which is important, we have a very good neuroradiological team. We have to ask them what we are looking for and where we suppose the lesions could be.
That was a great description. What a remarkable case. It was just the finger that provided the initial clues that then set up the rest of the evaluation that led to the discovery of the cognitive motor dissociation. And that's also a great point you make about being meticulous, not just in your examination, but then letting the radiologist know exactly what you're looking for so that you have the most interpretable results that are keyed into what you're looking for specifically, because it's really, really detailed when it comes down to it. So I appreciate that illustration. So I think to summarize for our listeners, I would say that what I've learned is, and what I've had reemphasized to me, is that detecting covert awareness is tough, but it does have prognostic implications that certainly make it worth looking for. And by practicing and using the motor behavioral tool, the coma recovery scale, working through the flow sheet from your paper, meticulous bedside examination, giving your time, you can detect awareness when it otherwise would be missed or otherwise required fancy testing to detect. That's a lot of times just completely inaccessible to some practicing neurologists. And so I think those were the big pearls that I gleaned from this article and from our discussion today. Does that sound okay, Karin? Any other points for the summary that I didn't touch on?
No, it's an excellent summary.
Karin, thanks so much for joining us. Everybody, go check out the article, especially the figures and the flow sheets. They're very, very well done and well synthesized. That'll be all for today. Thanks so much for listening. I'm Derek Stitt for the Neurology Podcast.
Thank you, Derek.
Hello, this is Hallie Alexander from Wake Forest University, and today I'm here with Dave Greer, professor and chair of neurology at Boston University and Boston Medical Center. He's joining us today to talk about the updated guidelines for brain death criteria in adults and pediatric patients, which was just published in Neurology this month. So, Dave, thanks so much for joining us.
Pleasure to be here. Thanks for having me.
I wanted to make sure that we went through all of the updates to the guidelines and everything, but can you just start by summarizing what are the main changes and updates from the previous guidelines?
This guideline is, I think, very exciting, and it's been years in the making. And it finally integrates guidance for adults and children into a single guideline and provides a comprehensive and really practical way to evaluate somebody who sustained a catastrophic brain injury to determine if they have brain death or not. It updates on the prerequisites for brain death determination, the examination, the examiners, how many are required, and what kind of qualifications they should have. It updates on the best way to do apnea testing, both meticulously but also safely. And it provides updates on ancillary testing also. I'd strongly encourage your listeners to look at our article that was published in Neurology, Clinical Practice, where Matt Kirshen and Ariane Lewis and I really outline the differences between the old and the new guidelines, really to make it easy for people, because otherwise you're looking back and forth between the two guidelines, and we want you to understand exactly what's different now. So that's hopefully a good resource for you. We also provide new guidance on what to do in the setting of a hypothermic patient, whether it's iatrogenic or environmental. Patients with a primary infratentorial injury or brainstem hemorrhage, for example, patients with pregnancy and possible brain death, patients on ECMO, and patients who have diabetes insipidus or who do not, and what to do in those circumstances. So hopefully we provided a lot of good practical guidance and been evidence-based or consensus-based as the case required.
Yeah, thanks so much for that review and pointing us toward that additional resource. I noticed, as somebody who reads EEGs, that EEG was removed as one of the possible ancillary tests. Do you want to talk about why that decision was made?
The issue with EEG is twofold. One is that it doesn't measure brainstem activity at all. And so it's not a great test to use as an ancillary test, and really never has been. In the early going, when this first came out as an ancillary test, it was meant to be used in conjunction with evoked potentials, which could, to at least some degree, assess brainstem integrity. But in EEG, scalp EEG itself would not measure anything in terms of electrical activity in the brainstem or viability. And so it's not good from that standpoint. And it's also not good because in the ICU setting, as you know, there's a lot of electromagnetic interference, and you can get little blips, which you don't know if it's coming from the environment or it's coming from the patient. So you can have false positives and false negatives with EEG, and we felt that it was really time to do away with this as an ancillary test.
Yeah, I think that makes a lot of sense. And I know for the pediatric patients, having the two providers do an exam, that's something that still stands, right? But are there any changes to who those providers can be or anything like that?
Yeah, and it was really important to the pediatric community, and we very much respect that there remain 2 examinations and 2 apnea tests. And so that was really a crucial thing for us to include. And we established that there needed to be still an intervening waiting period between the 2 examinations, but it was 12 hours across the board, regardless of the patient's age, assuming that they were of an appropriate age to be determined to be brain dead in the first place. In terms of the qualifications of the examiners, we really want people who are expert in this and are doing it a lot. And so this could include neonatologists, it could include pediatric intensivists, it could include pediatric neurologists. Any of the above would be appropriate, provided that they had the expertise and the training. And the Neurocritical Care Society has really tried to put forth a really great online training course to help people, both adult and pediatricians, to do this correctly. There wasn't previously a course for this online, and now there's a way to get trained and certified. And hopefully people can do in-person courses also, such as put on at NCS, but also at the AAN meeting every year. We put on a course that includes guidance for pediatricians too. So hopefully that's helpful for people.
Can you talk about, too, what are some of the differences between diagnosing brain death in adult patients and pediatric patients? I know you mentioned there's an age cutoff, if you could talk about that as well.
Yeah, so we don't want anybody being declared brain dead at less than 37 weeks gestational age, because we really don't know when somebody is in a permanent state younger than that age. So that's the cutoff. There used to be different age groups that had different rules with the prior pediatric guidelines. And as I said, that's really been changed for the new guidelines where it's much more straightforward, I think. There are obviously differences between adults and children. One very specific one is blood pressure. We wouldn't require a child to have at least an arterial pressure of 75 like we do in adults. So we carve out the difference for blood pressure, that it has to be greater than the 5th percentile for age for both SBP and the mean arterial pressure as well. We emphasize that in children who are less than 2 years old, they often have unfused sutures and open fontanelles. So that changes the intracranial physiology, and the patient may take longer to determine whether they've had a clear, irreversible, or permanent injury. So we really want people to err on the side of caution. As I mentioned earlier, 2 examinations and 2 apnea tests in children. In adults, we emphasize at the very least 1 examination, but we say that 2 examinations will provide greater certainty. So we really encourage that, but only 1 apnea test in adults, and that's always been the norm. And then the final difference, I would say, is the use of transcranial Doppler. This has not been validated in children, so it's only an acceptable ancillary test in adults until it does get evaluated thoroughly in children. So those are some of the major differences between the 2.
And correct me if I'm wrong, but one of the major reasons for providing the update was that there were some discrepancies in brain death declaration that were varying by different locations and different providers. They were being done in different ways. Are there items, even with the update, that we would still expect to vary based on location?
We recommend, first and foremost, that clinicians follow their state and their local hospitals' legal requirements and processes. And some hospitals may choose to have 1 versus 2 examinations in adults, but in pediatric patients, all states should require 2 examinations and 2 apnea tests, because that is really the standard. I think that that's going to be one of the differences moving forward, is that still some states may require 1 versus 2 examinations. Otherwise, there shouldn't be a lot of variability in brain death. You shouldn't be dead in Wyoming, but not in Virginia. And so the prerequisites, the examination, the apnea testing, the ancillary testing, the documentation, all of those things really should be pretty standard. And we tried to provide guidance in terms of checklists and very rote information for people so that they could really just follow the guidelines as we put forth from the AAN. We tried to make it as simple as possible. So hopefully people will find it that way.
We appreciate those efforts to make it as standardized and easy to follow as possible, like you've done with these guidelines. So you've updated, adding the information that we know about targeted temperature management, ECMO, pregnancy, as you stated. But what questions still remain?
So we have a lot of questions that remain. And at this point, I'll refer you to the World Brain Death Project that we published in JAMA in 2020, where we put forth over 50 research questions that need to be answered. Some of them are regarding the use of CT angiography. I know that people really want to use that, but it hasn't been validated against a gold standard blood flow study and needs to be. So we need prospective studies that look at that and ensure that there's a very minuscule, if any, false positive rate, or at least that the technique has been figured out so that you can eliminate false positives with CT angiography. But that's just one of many, many questions that we raised. So we've started up a big national database running out of Boston University and Boston Medical Center, where we have thousands of patients with brain death. This is all retrospective at this point, but it'll also have prospective arms. But this is how you answer these questions that remain. Unless you put lots of centers together and really collect the data and look at it very systematically, you can't answer these questions. And I should mention that my friend Matt Kirshen at Children's Hospital of Pennsylvania, they also have started the pediatric database likewise to try to answer these questions. So we are not saying that this is the end for brain death. We expect the field to grow and to mature. And so by the time we do new guidelines in the next 10, 15 years, hopefully we'll have really good data from these studies to be able to understand how to do this perfectly every time.
And likely some new technology to add into the mix by then as well. So before we go, is there anything else you want to add?
Well, I think the most important message from the guidelines is to err on the side of conservative, meaning that if you have any doubt about the permanence of the patient's condition, do not declare brain death. Don't ever be in a rush to declare brain death in a patient. Make sure that you're allowing for all the prerequisites to be met. And if you think that there's any potential confounding, you really have to either wait that out or get a tried and true ancillary test to make sure. But we don't want people, for example, just getting a spec study to let's see if they're brain dead. And unfortunately, we see that a lot. And that's really very faulty practice. We should be absolutely sure, even when you know that you're going to get an ancillary test, make sure that you're testing the clinical exam to the fullest extent possible, because if you find any signs of brain function, the patient is not dead, and you shouldn't be getting an ancillary test in the first place. So I think those are a couple of really important messages that I would share at the end here.
Excellent points. Thank you for sharing that. So again, I've been speaking today with Dave Greer about the updated guidelines for adult and pediatric brain death. You can find the full report in this month's issue of Neurology. There's also a nice summary in Neurology Clinical Practice. And for even more information, the topic is also covered in the October 19th issue of Neurology Today. Dave, thanks so much for joining us.
Thank you for having me.
Hi, my name is Neha Dangayich, and I'm a neurointensivist at the Icahn School of Medicine at Mount Sinai, New York. I'm also the editor for the Neurology Clinical Practice Accelerator. I'm excited to talk about a study that I think is going to be very high impact for our field in neurocritical care and neurology as a whole. I've got our guests, Susanne Muehlschlegel and Adeline Goss, and I'm going to have them introduce themselves before we jump into our conversation.
Hi, I'm Susanne Muehlschlegel. I'm professor of neurology and neurocritical care at Johns Hopkins. We'll be talking today about a study that we conducted while I was at my prior institution, the University of Massachusetts Medical School.
And I'm Adeline Goss. I'm a neurohospitalist and the Associate Chief of Neurology at Highland Hospital in Oakland, California.
So thank you both for joining us, and let's dive right in. I'm going to ask you, Addie, about the idea of this study and how did you conceptualize it? Why did you choose to study this?
Sure. Well, I can speak to the idea, at least to my side of it. When Susanne and I started this project, I was still in neurology residency at UCSF, and I was having those early professional experiences of facing a room full of family members who all want to know how their loved one is going to recover from a severe stroke or intracerebral hemorrhage. And
As we know, prognostication in critical neurologic illness is really challenging because these illnesses occur suddenly and the prognosis in the acute period is often very uncertain. Plus, in neurologic illness, there are so many domains of recovery, not just survival and functional outcomes, but also things like memory, personality, identity, mood, all of these other aspects of brain function that can make us, that make life meaningful and can be so varied and so personal and hard to measure. And what I saw in residency, sitting in and just observing lots of these family meetings and trying to figure out how to do this well, was that there was a huge range of ways that clinicians communicated prognosis. Sometimes they were really precise and citing population level data and describing prognosis in terms of best case, worst case, most likely scenarios. And at other times they were pretty vague. I heard a lot of phrases like, this is a devastating brain injury, or she has little chance of a meaningful recovery. And I wondered, what does devastating mean? What does meaningful mean? And, what is the best way to deliver prognostic information to families in the face of this uncertainty? The truth at this moment is that there are no evidence-based guidelines around how to communicate prognosis in critical neurologic illness. And what our group realized was that to get to a point where we have evidence-based guidelines, we need to understand how clinicians convey prognosis for these patients in real life now. And so we decided to tackle that question. Doug White at the University of Pittsburgh and colleagues have done extensive work analyzing communication in the general ICU setting using family meeting transcripts. And Susanne, of course, has also done research around shared decision-making, including qualitative research at UMass. And she was gathering a similar database of family meeting transcripts at UMass. And so we worked with Doug White's group to analyze prognostic communication in family meetings, specifically for this population of patients with critical neurologic illness.
Addie, thank you for sharing the inception of the study. And Susanne, I want to get a sense from you, how difficult is it to conduct these kinds of studies? What are some of those challenges, barriers in conducting these kinds of studies?
In short, it's actually quite hard to do this type of research for several reasons. One, it's a really sensitive topic. We obviously have to get consent from both the clinician in the room and the family members in the room. And most of the clinicians usually agree, although we've had a few not agree to be recorded. But in terms of surrogate decision makers, on average, about 1/3 do not want to have anything to do with the recording because it's either too sensitive, they're too stressed. Sometimes they're even worried about data safety. And I think when we analyze these kind of things and do mixed methods, it's important that we're very rigorous in how we analyze this qualitatively, that we use best practice, that we follow a checklist, that we use 2 coders to develop the code book and code some of the transcript simultaneously until we have high inter-rater reliability. So when you read the methods and you don't know much about qualitative research, there's a lot of science behind how we do this. And I think another challenge that's rarely mentioned, we listed in our limitations, obviously, is that we can never record all conversations. As we all know, there's these side conversations, often unplanned, sometimes everybody just standing in the room where important information is transmitted and we're just not able to capture it because we don't know ahead of time. We weren't able to do the formal consenting. And so I think that's just one of the downsides of analyzing these family meetings. And the other thing is too, sometimes, the clinical team may tell us, oh, no need to record. This is just an update. We won't talk about prognosis. And sometimes the team then does not record, but then often a conversation will go into prognostication. Why? Because families always want to know about it. And so we learned, and we're now erring on the side of let's rather record and maybe not include that in the analysis if the prognosis was really not discussed, but most of the time it actually goes into that direction.
Do you think recording these conversations changes the flavor or nature of these conversations? Because some people may just be so much more conscious when they know that somebody's going to record this and perhaps analyze this. What do you think?
Yeah, that's always a possible confounder, right? It's actually called the Hawthorne effect. We always list that in our limitation section where physicians may behave better than if they, or maybe speak differently if they weren't recorded. But to be honest, it biases our results towards better, right? So if we consider that maybe Hawthorne effect is there, that means what we find and document in reality might even be worse than what we're actually documenting, definitely not better. And so I think it's important to note it. It's a possibility. We can't really correct for it.
So let's talk a little bit about the key findings from your study. So your discovery that physicians are not using probabilistic statements during family meetings while discussing prognosis. And Addie, you mentioned that a lot of physicians, and you found this also in your study, tend to use these vague terminologies and they don't provide probabilistic statements during family meetings. Why do we think that is happening? And were you surprised by the findings of your study? Perhaps both Addie and Susanne, if you want to share that with us.
Yeah, there were a number of findings that were surprising. To back up, what we basically did was we analyzed de-identified transcripts of 43 audio-recorded clinician family meetings from 7 U.S. medical centers. And these were all for patients with severe neurologic illness who required intensive care. So patients with intracerebral hemorrhage, severe stroke, traumatic brain injury, et cetera. And then we coded every prognostic statement that a clinician made, which came out to 512 statements, and then used a coding framework that had been developed previously by Doug White and colleagues to divide those statements into these two categories, which you alluded to. And just bear with me because this can take a moment to just understand the terminology. So the first category is probabilistic, meaning that the clinician was estimating the likelihood of an outcome occurring. So, for example, they could do that using numbers, like she has a 75% chance of surviving, or using a word like likely, or the majority of patients survive, or she'll definitely survive. And that's in contrast to the other category of non-probabilistic statements. And this means that the clinician characterized an outcome without giving any kind of estimate of how likely it was to occur. And this is a huge range of different types of statements, like emotional words, I'm worried she won't survive, or saying she could survive, or we don't know if she'll survive. So none of these phrases tell you how likely it is that the patient will survive. So every statement got one of those two codes, probabilistic or non-probabilistic, and then we also just identified what type of outcome they were describing: survival, function, physical function, cognition, etc. And what we found was that most prognostic statements were non-probabilistic, meaning that clinicians didn't actually estimate how likely an outcome was to occur. In fact, there were 21% of family meetings where there was only non-probabilistic information. There was no estimate at all. And I thought that was surprising. Also surprising, maybe less so, is that clinicians offered a numeric estimate of prognosis in only 16% of meetings. And then this other idea, this other framework that is quite common of sharing a best case and worst case and most likely scenario, that actually never occurred. But at least people did describe best case and worst case scenarios in only 28% of meetings. And just finally, in our analysis, we applied univariate and multivariate binomial logistic regression to look for independent associations between the type of prognostic language and what type of outcome the clinician was describing. And maybe not surprising to people in our field, after adjustment, we found that clinicians' prognostic statements about cognition were less likely to be probabilistic than statements about survival or physical function. They were less likely to offer any kind of estimate.
Yeah, and if I may chime in, it's quite surprising what we found. And it's also important that we finally have data on what actually happens at the bedside. And you won't even believe how many times colleagues tell me neurologists or even neurointensivists are the best at having these conversations. And that may be good, but now we actually have data of what they do or don't deliver. We know from other studies our group did as to what families would like to hear. They actually would like to have an estimate if possible, even if it's just a ballpark. Everybody knows it's uncertain. We will never do better. We'll never improve. We'll never have best practice guidelines if we don't document what we actually do currently so that we understand where the gaps are and what we need to improve.
Why do you think we're not good at talking about prognosis, even when there is data that tells us about these probabilities or the ballparks? Why are we afraid to use this during our family meetings at the bedside?
Susanne and colleagues have done several qualitative studies in traumatic brain injury in particular, where they spoke to physicians and tried to identify why they tend to be less precise in their prognostic communication, and specifically why they tend to avoid numeric estimates, and identified several reasons. So one is that physicians often don't trust family members to be able to interpret probabilities appropriately. Another is that they don't always trust the accuracy of the data that we have and the quality of the existing outcome prediction model data. And third, they're often worried about creating false hope, which is something that families worry about too. And there have been previous studies also in the general medical literature that have found that residents in particular lack confidence around disclosing prognosis in general to patients and families. I would also just add that I think these conversations are emotionally and cognitively and morally difficult for physicians. And I think that makes the prognostic communication part vulnerable to bias, especially for physicians who have little experience or maybe some strong personalities or a nihilistic perspective in general on acute neurologic illness.
I couldn't agree more. I think Addie stated it all. Also, we've all had experiences, but I think it's usually the very inexperienced trainees, younger physicians, or those who are somewhat senior and believe in themselves that they've seen it all, where I think we have to be particularly careful. And I try to catch myself every time. Is it unbiased or as unbiased as possible, what I'm telling families?
You bring up the idea of trainees and perhaps even junior attendings with lesser experience not being as certain in how they're communicating the prognosis and their ability to predict what's going to happen in the future. In your study, we see that about 70% of the respondents were attendings, if I'm not mistaken. There 70% of them are attending. So despite them being attendings, and we're seeing very infrequent use of probabilistic statements in the communication of prognosis, it made me wonder, the more experience we get, the more we learn, do we become less certain about our ability to prognosticate? Is that what's happening here?
I think uncertainty is there no matter what training stage you're at. I think folks may be more aware of that uncertainty and maybe do become more cautious. However, we need to know that you can be cautious and express and acknowledge uncertainty, yet still give them somewhat of a ballpark and tell them how uncertain it is and that no one will have a crystal ball. You can even acknowledge that they might be disappointed hearing that, but I think it creates trust with the family if you acknowledge the uncertainty, but do the best you can using the data that is available. I think it's important to know it's a reflection of who usually holds family meetings. So I was actually glad to see it 70%, but I may also add it could be a methodological bias because half of the recordings were from one center, UMass, and that is just a practice at that one center. It may be very different if we record at other centers where maybe it's the fellows or the trainees who are asked to have those family meetings.
How do we move prognostication from this realm of it being an art and with all this uncertainty into data-driven science? How do we do that?
So I think just even doing this study and continuing this study is an important step in putting the science behind this so that we can finally stop talking about neuroprognostication being an art. I think we need to look at physician or clinician family communication like a procedure where there are standards and best practices and where you can actually learn and train and maybe even get certified one day, who knows, and then repeat training and keep your competencies up and, up to the scientific literature. So that is really kind of my future vision of this. But right now we're doing two things. Number one, we're expanding this work to my new center And I'm very excited to do that for various reasons. As I said, half of the cohort that we analyzed here stemmed from one center. And the second thing we're doing, we're already, as you mentioned, we're already in the process of developing decision aids to promote better shared decision making, pilot testing them, and hopefully one day doing a larger multi-center trial with that. And the ultimate goal is really to increase shared decision making, prepare families, and maybe even lower the variability of how we present the important data to make these difficult decisions.
Thank you so much, Susanna and Addie. I'm going to say I really love the fact that you said that conducting family meetings and neuroprognostication should be treated like a procedure. We have been living in that realm where Susanna and I had an opportunity to chat about this even before the podcast, that this is not just an art. There is hard data-driven information that we should be able to translate for our patients and family members who are going to make some very, very important life-altering decisions about what that new state of normal is going to look like. And it is our responsibility to translate that data into a language that our patients and their loved ones and family members can comprehend. And if we don't do that kind of translation, we're doing a disservice, not just to our patients and families, but also to this emerging body of literature. So thank you again, and until next time.
Thank you.
Thank you very much for having us.
Well, hi, I'm Maisha Robinson from the Mayo Clinic in Jacksonville, Florida. I'm joined today by my colleague and author of the paper, The Aligned Framework, a parent-informed approach to prognostic communication for infants with neurologic conditions, Monica Lemmon. Monica is a child neurologist at Duke University. So prognostication, many of us know, can be challenging in a number of neurologic diseases due to uncertainty, really, about the course of disease, and really because of that desire also to maintain a sense of hope for patients and their family members. Now, I'm an adult neuropalliative care physician and certainly understand the amount of care which has to be provided when having these conversations. However, when discussing prognosis with parents of children with neurologic conditions, even more sensitivity must be applied. And given this, I'm delighted to be able to talk to Monica about her approach to these important discussions. So let's get started. Monica, there are a number of tools and guides that are available for clinicians already to use when discussing prognosis or when they're delivering difficult news. Can you spend some time telling us why we need a specific framework for discussing prognosis with parents of infants with neurologic conditions?
Absolutely. It's true. There are quite a number of outstanding communication skills, tools, and frameworks out there, several of which have arisen from the disciplines of palliative care and oncology. And there is no doubt that many tenets of high quality communication are universal. I do think that there are some key differences in how we deliver information in this particular context as compared to adult settings. For example, in adult settings like the ones that you practice in, many conversations might center the person's life and function prior to a neurologic event or illness, or they might focus on the potential for loss of independence. And in the context of neonatal conditions, parents already expect to take home a baby who's entirely dependent on them. Often our conversations are about what it looks like to extend or change the nature of that dependence. But really, when we set out to do this work, our primary goal was to center parent voices, to ask them their preferences for how to hear prognostic information. A number of the themes and recommendations you'll see in the paper that arose echo principles that have been put forward in other tools. And I think it's encouraging that the participants in our study endorse some of these longstanding ideas.
As you spend some time looking at how to have these conversations well, you may have come across some common pitfalls that clinicians may run into when discussing prognosis with parents. Can you tell us how the aligned framework might help?
I'll say that not only have I come across a lot of pitfalls, I myself fall victim to a number of pitfalls. And I would say first, really a common pitfall we see is lack of preparation. And our findings highlight the importance of preparing thoughtfully for serious conversations, considering the right venue, who the family wants present, ensuring that our teams are on the same page. And the good news is that the participants in our study gave useful suggestions on how to do this better and how we might think about preparing for serious conversations in advance. The second is avoiding hard news, not saying the tough thing. And participants in our study directly talked about how sugarcoating or avoiding difficult news could undermine their trust in the team. And in some ways, I find this finding helpful in reassuring clinicians that it's okay to share serious news and to do so transparently. I could keep going, but I'll end on information overload. I think our findings highlighted that parents appreciated when clinicians avoided jargon and they paced information delivery. In my own experience, this requires some intention and some effort. I think many of us are very good at going on a long spiel. That's something that I do a lot when I'm nervous. I start to talk about things that are more comfortable to me. And that could be detailed medical information, that EEG finding or that MRI finding. A useful strategy to combat this is to first recognize it and to think about ways to mitigate it, and also to create space within your spiel to check understanding and to make room for questions.
You mentioned that parents want clinicians to be transparent when having conversations about prognosis. And one of the things that I found very interesting about the paper is really the importance of that informed step that you all mentioned in the framework. And so focusing really on being as honest as possible when discussing prognosis, but also providing information that's balanced. Will you talk some about how to provide balanced information, particularly when the prognosis is not expected to be good?
I think at first glance, the two findings you're referencing, the one to be transparent and also to provide balanced information, they might seem at odds with one another. But as we've thought about this more carefully, they can easily occur alongside each other and they're quite aligned. So participants described two primary ways in which they hoped for balanced information delivery. First, they appreciated when clinicians talked about function in addition to impairment. For example, imagine that you're talking with a family of a child who's not expected to be able to speak. One might traditionally use language like, your child will never talk. One way of describing that outcome in a way that centers function might be, your child will communicate her needs through sounds or movements that you come to recognize, and not through words like we're speaking now. The second way of delivering information doesn't provide falsely positive news. It simply describes the outcome in a way that centers what the child could be able to do, as opposed to only speaking to impairment. Another way to think about this is to include speaking about development and function more broadly, and not isolating one's counseling to the domains that we think are going to have impairment. And so in my own practice, I'll often introduce this type of talk with something like, sometimes we spend a lot of time talking about what kids might not be able to do. I'd also like to take a moment to share what I expect your daughter will be able to do. Children with this type of brain injury laugh, smile, they recognize their parents' faces. The goal of language like this is to paint a more full and honest picture of what life might look like. The second way that families described the need for balanced information delivery was not to repeat grim news unnecessarily. And importantly, this didn't mean never sharing grim news. It simply emphasized that once it was clear that families had heard, processed, and understood a certain outcome, repeating that information without a reason to do so could be painful. Just to speak a bit more to this, there's no doubt that there are some cases in which this particular principle might be less relevant, and this framework isn't meant to be prescriptive. Instead, it's meant to serve as a guide that you can use as the situation requires.
I love the way you phrase some of that. This is what we think your child might be able to do, and this is what we expect them to be able to do, versus just focusing on some of the unfortunate aspects of the condition. That's wonderful and a good point that I can take with me. Monica, what did you find most surprising about what the parents shared regarding their experiences with clinicians discussing prognosis for their children, and why?
I found a lot of things surprising in this data set. I think one of them is in some ways the lack of variability in the findings. There's no doubt that each of these families had, very unique, important perspective and heterogeneous experiences. And despite that, we were able to hear salient, repeated ideas throughout the data. I think that helped me feel confident that the themes we present here are things that we can add to our toolkit as we think about counseling families at large. The other piece is a lot of what we just talked about. Some of the ideas about balanced information delivery were really humbling. And frankly, my counseling has changed as a result of that finding. And as it has, I've realized that describing outcome in that way has actually been really hard. It's required me to shift my thinking. It's required me to read more, not only about a given outcome, but really concretely about how that outcome impacts function and how that might show up in daily life.
May I run a case by you and ask you to walk us through how you would use the Align framework to discuss prognosis with the parents of this newborn?
Absolutely.
So a baby is born at 28 weeks via emergency cesarean section after preterm rupture of membranes leading to fetal distress. APGAR scores were 3 at 1 minute and 4 at 5 minutes. She was taken to the neonatal ICU where her evaluation revealed a grade 3 intraventricular hemorrhage. The result of the ultrasound was shared with her parents, but they understandably had many questions about what this will mean for their little girl. How would you approach this?
There's probably variability in how listeners might estimate prognosis in this scenario, and one might ask a bunch of questions about the imaging findings or other prenatal or neonatal factors. And I think what's most helpful here is rather than to focus on estimating prognosis, let's just think about how we might communicate it. And let's assume that this is a child with a risk of hemiplegic cerebral palsy and potentially some other neurodevelopmental impairments, but that, some children with this type of injury may go on to have typical neurodevelopment. So I would start by thinking about my approach. Learning who the family might want in that conversation. Is there a bedside nurse who knows the family well? Can there be a social worker present? Ask the family who they want there. And, I'd check in with my neonatology colleagues and colleagues on other teams to make sure we're on the same page, not only about the plan, but about how we see both the short and long-term outcome. Once we've started the conversation, I would lead prognostic discussion with questions or prompts. So things like, tell me what you've heard about your daughter's brain. I might ask permission prior to proceeding, and that might look like asking a question like, when something like this happens, many parents want to know more about what this means for their child's future development. Would you like to talk about that today? After that, I might ask a bit about information preferences or about what aspects of development are most important to them, and then I would hopefully tailor my content accordingly. When I get into the prognostic counseling, I often start with a narrative, telling the story of what the next steps in the hospital might look like, when we might repeat imaging, how we'll monitor for post-hemorrhagic hydrocephalus. Hopefully along the way, I'm interrupting my spiel to check in, to check for understanding, to allow space for questions. And then I begin to tell the story of what life might look like at home, thinking about early intervention, medical appointments, things like that. And when I get to talking about outcomes, I often separate these by domain because I find that lumping them together often does a disservice to our ability to describe the impact on daily life. And so in this particular case, let's say I was focusing on motor outcome. I might say something like, when we think about motor outcomes or movements, there's a big range in what's possible. On one end of the range, children have typical development and walk and run and use their arms like most kids do. On the other end of that range, children have weakness and stiffness on their right side. For these children, they might need a device like a brace that they wear to support their muscles. They may not be able to use their right hand and instead might need to use their left hand to feed themselves or to write. What's most likely is something in between, in which your daughter has some weakness on her right side that you and others notice when she walks or uses her hands, but she can do those things without extra support or extra equipment. After all of that, I would hopefully stop and say, that's a lot of information. What questions do you have? also along the way, I'd hope that I would communicate with empathy, that I would lean on my colleagues with expertise in providing emotional support to step in when I needed help. And I would come ready with peer support organizations that might be relevant to a given family. In some settings, I might even look at resources with parents in real time to help them identify information that's helpful and information that's accurate.
Thank you so much for that answer. That best case, worst case, most likely case scenario is a great tool to use really when communicating prognosis. So I've learned a lot from just talking with you, Monica, but if you had to offer 2 or 3 pearls for neurology clinicians about how to approach prognostication discussions with parents of children with neurologic conditions, what would they be?
I think really it boils down to a few key ideas. Treat serious illness communication with reverence. These conversations are high stakes, and that means preparing for them. Defining and practicing the headline statement or the key idea that you want to communicate. Understand and minimize biases you might bring to the table. Invest time and resources into continuous improvement. Seek education where you can find it. When I think about actually holding the conversation, I really think we should lead with listening. Understand what the family already knows, elicit their goals, understand how they like to hear information and what outcomes are most important to them. And I think finally, give yourself some grace. This is really hard to do, and we all might say things in ways that we wish we hadn't. And if that happens, it's okay to own it and to say, I'm sorry, I wish I would have said that differently. Can I try again? And the key is not to do a perfect job every time. The key is to use each experience as a way to grow and a way to improve and to do our best.
Well, thank you. And thank you all for listening to this episode of the Neurology Podcast. Monica, it's just been an absolute pleasure talking with you about your paper, The Aligned Framework, a Parent-Informed Approach to Prognostic Communication for Infants with Neurologic Conditions. It's published in the journal Neurology, so please check it out.
Thank you so much. It's been a joy to be here.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about. The views and opinions of the participants in this podcast do not necessarily reflect those of the journal Neurology or the AAN. Disclosures of the participants are included in the show descriptions, reached by a link on the neurology.org website.